Yeah. Good afternoon, friends. I wish you all a very good afternoon, and I request Dr. Atul Doshi to start the proceedings.
Good
Dr. Atul
afternoon,
Bhai.
everybody. Today's chairperson is Dr. Ajita Bhosle. She is a budding physician and clinician, special interest in non-invasive cardiology and diabetologist, focuses on preventive medicine and holistic approach in treating patients. Today we have 297th webinar. Madam, you can proceed, madam.
Thank
Ajita,
you,
Yeah.
sir.
madam. Yeah.
Yes. Good
Ajita.
afternoon, all. Thank you, Dr. Atul Doshi, sir, for that kind introduction. Without further ado, let's start with today's webinar. Today we have with us a young, dynamic, and an excellent speaker, Dr. Natasha Tipnis Shah. Dr. Natasha Tipnis is a consultant neurologist at Jaslok Hospital. She specializes in diagnosis and management of epilepsy. This includes generalized as well as focal seizures. It is all. She also specializes in functional seizures. She is competent in treating all the neurological conditions. Today, she is going to guide us on neurological problems in diabetics. Over to you, ma'am, Dr. Natasha Tipnis. Ma'am, you can start.
Hello.
Yeah.
Yeah, hello. Thank you so much for the invitation to speak on complications of diabetes. I've tried to keep my talk very short and in keeping with what is generally expected of the general physicians in diabetes. At the end, we have lots of time for questions. So, in case anybody has their questions, please ask. I would once again like to thank the GP Association for continuing to give me opportunities to speak on various topics. And thank you so much, the chairpersons and the other delegates once again. So give me 5 minutes to just start screen sharing.
Yeah. Thank you. Yes. Yeah, madam, enlarge it. Madam, enlarge it. Yeah, fine.
Can
Fine.
everyone
Okay.
see my slides, sir?
Yes, madam.
Yes,
Yes.
madam.
You can carry on.
All right. Okay. Uh, so beginning. So we need to understand that diabetes is something that affects every organ system, and the neurological problems are no. Just give me a minute. Sorry, there is some problem. Yeah. So diabetes affects nearly every organ system, and you know that the nervous system is no exception. In fact, it is one of the systems that is most affected by diabetes. And they are very common. They are still underdiagnosed, even though you will say that probably diabetic neuropathy and other complications of diabetes are pretty well sought after and pretty well looked after. I still feel that we have a bit of room for better diagnosis. Now, the objective for today is just to simplify the understanding of neurological issues and most important, to recognize them early. So this is a quiz, and I want all of you, if you have a pen or a paper or if you have your phone, to just answer these questions. We'll have the answers towards the end. We'll have a post quiz also. But for now, all of you just take the pre-quiz for me, please. So what's the most common neurological complication of diabetes? That would be question 1. Can diabetes cause focal cranial
Get the
neuropathies?
chat box. Put in the chat box. Yeah.
Yeah, you could just, sir, you could just answer it in your on a paper or on a phone, and then we will do the answers at the end. Can diabetes
Good.
cause focal cranial neuropathies? That would be the second question. Is diabetic neuropathy reversible? Name one non-peripheral neurological complication of diabetes. And what is the gold standard test for diagnosing diabetic neuropathy? You need not answer the questions right now in the answer box or the question box. Just keep the answers with yourself. We will have the answers in the post quiz. This is just to enhance your own understanding of the subject. Moving on to now the presentation. So this is the overview. So what kind of complications of neurological system can you expect with diabetes? First of all, of course, we have the peripheral nervous system, which everyone knows and is very well aware of, sees every day. So you have the polyneuropathies, you have mononeuropathies, radiculoplexopathies. You have the central nervous system complications, most commonly the stroke, followed by cognitive dysfunction and sometimes diabetic encephalopathy. We will come to that. And then you have the autonomic nervous system complication. And when I mentioned in the beginning of the talk that I think there is a lot of scope for better diagnosis, I think I was talking about this. So the autonomic nervous system complications of diabetes are the least understood and the least diagnosed, and they are most often missed. So before we go ahead, all of you have to answer this question for me in your own heads. How many of you take diabetic patients' blood pressure in lying down and standing positions? And do you know what the diagnostic criteria of orthostatic hypotension are? Keep this in mind and then we move on. So before we move ahead, just a bit about how hyperglycemia causes nerve damage. So here, I have made it in the form of a cracker because that's what happens. There is, we just had Diwali and जब आप एक क्रैकर को जलाते हैं तो आप छोटा सा आग लगाते हैं एकदम ऐसा छोटा सा and then the cracker explodes. So the same thing happens, like hyperglycemia is the little bit of the matches tili or the fulgari which you're just putting in. And then you have these crackers which are exploding. So you have the sorbitol accumulation, you have the microvascular injury, and you have the protein glycation product formation, and all of this eventually cause the huge damage in the body. So here are the common neuropathies that diabetes causes. So you can see that we have the distal symmetric polyneuropathy. Now, distal symmetric polyneuropathy is the most common complication of diabetes. Okay. What do you mean by distal symmetric polyneuropathy? That you have a typical patient has diabetes for about 10 years, 20 years, maybe less, and has glove and stocking sensory loss. So glove and stocking is the place where you wear your gloves. So that is your hands, and stockings is the where you wear your stockings. Burning feet. This is such a common symptom in India. People will come to you say मेरे तलवे जल रहे हैं, ऐसा लगता है कि पैर के नीचे आग लग गई है. And the other common problem here is nocturnal pain. So just a bit about nocturnal pain. If a patient comes to you with pain which is purely nocturnal, सिर्फ रात को दर्द होता है, it can be, you have to ask the patient what is the kind of pain that you get at night. If it is burning pain, it is likely to be diabetes and diabetes associated polyneuropathy. So you should definitely get the HbA1c checked. But I'd just like to make a note here that everything that pains at night is not diabetes. So sometimes your patient can have what we call restless leg syndrome, in which case the patient will say that my feet feel weird and I feel like I want to keep moving them. And if I get up in the night and I take a walk and come back, then I feel really good. Restless leg syndrome can be because of a number of causes. It is, of course, associated with, as you know from our discussions on Parkinson's and other movement disorders, that it is associated very closely with Parkinson's. It is associated very closely with other movement disorders. But one important thing to understand is that restless leg syndrome is also associated with iron deficiency anemia. So if a patient is coming to you with pain at night, first of all, try and categorize the pain. Is it burning pain? Is it pins and needles of pain? Is it numbness? Or is it maybe restless legs? And if you have restless leg syndrome, supplementing iron can do a great job for you. The other thing that you need to check in people with nocturnal pain is B12. So check your vitamin B12, check your vitamin D3, check your iron levels. This is something that you can easily do at a general practitioner level. Number two, the second type is mononeuropathies. Now, mononeuropathies means very simple, it's in the name, mono, single nerve neuropathy. It could be cranial nerve 3, 6, or your median nerve, ulnar nerve, femoral nerve, radial nerve. These are usually acute in onset, and paradoxically, the treatment is steroids, which might increase the glucose levels for a bit. I have seen that there is a lot of reluctance, a lot of stress, and a lot of problems associated in not only the patients but also the general practitioners' minds about the use of steroids. Bear in mind that perhaps the only treatment that is effective in an acute neuropathy is steroids. If you give steroids in time, the nerve inflammation is taken care of, and we might be able to reverse it. With the exception of IVIG that works in the other kind of neuropathy, which is your immune mediated neuropathies, we really don't have other treatments. So sometimes you have to take an informed decision. This can be taken in combination with the general practitioner, the neurologist. You can involve a diabetes specialist or an endocrinologist if need be. And amongst all of you, you have to take a decision whether giving the steroid is necessary or not for this particular patient. The third type of neuropathy is your plexopathies. Plexopathies are quite easily seen in your elderly patients with diabetes. We all would have had elderly patients where we see these plexopathies. So the thing about plexopathies is that you usually see pain with proximal weakness. You might see weight loss, or sometimes it is called amyotrophy because of the you see wasting of the muscles, which is why it is also called amyotrophy. So these are the types of peripheral neuropathies that you see in diabetes, and very nicely put up in a diagram form. Our DM neuro students are usually asked to form these diagrams. So remember, for this A type is what you will clearly see on a day-to-day basis. I think everyone is aware of the treatment options. You start with medications like gabapentin or pregabalin. The recommended doses are up to 300 milligrams of pregabalin and up to 1800 milligrams of gabapentin. I know none of us give these doses, but don't be afraid to up escalate. A lot of sustained release formulations are now available in the market, and they help to reduce the side effects and give a better patient experience. So please explore the sustained release preparations. Another word of advice would be you can explore the various gels and local applications of gabapentin and pregabalin that are available in the market. They might give the patient some relief. For the focal neuropathies, as I discussed, where a single nerve is involved, you must speak to the neurologist about whether a steroid is going to help the patient. Similarly, for the amyotrophy. The autonomic neuropathy can present in various different ways. First of all, it can present with delayed gastric emptying, very commonly seen in diabetics, and delayed gastric emptying causes quite a lot of problems, including constipation, flatulence, eructations, GERD, etc., etc. But one more thing that delayed gastric emptying actually does is that it delays the emptying time of certain medications as well. So, very often mislooked complication. You might want to speak to your gastroenterologist about medications that can be used to speed up the gastric emptying time and hence allay the complications. Most of the diabetic patients also have other illnesses, and hence if you have constipation, for example, if your diabetic patient also has any form of extrapyramidal symptoms or Parkinson's, constipation can be terrible for this patient. So when the diabetic patient comes to you, ask about constipation, ask about diarrhea, ask about alternating diarrhea and constipation. Also, a lot of these patients will inevitably be elderly. And we all know that with increasing age, the risk of cancer increases. So when your patient comes to you, focus on whether the bowel movements are okay. Another thing is the urinary bladder. Now, urinary bladder in patients with diabetes can be affected in a multiple various ways. But one of them is the autonomic neuropathy. The second is the lumbosacral plexopathy. Again, your neurologist friends will help you to differentiate between both of them. But as general practitioners, important to include this in your checklist of what will you ask the patient with diabetes when the patient comes to you. You have to ask whether there are any urinary problems. Is there any incontinence? If there is incontinence, is it stress incontinence? Is it urge incontinence? Is there any retention of urine? Is there any complaint of incomplete evacuation of urine? Of course, in a male patient, this can be due to prostate problems as well. So we have to take care of all of these varied parameters and keep these things in mind and ask these questions of your patients with diabetes. We all know the various medications that we use, but there is a specific problem that exists very commonly in patients with diabetes because of autonomic dysfunction, which is called detrusor sphincter dyssynergia, where the patient experiences incontinence, and sometimes medications like mirabegon are quite useful in treating this. However, word of caution, any medication that is given for any urinary complaint is always to be discussed with a urologist, because and has to be accompanied by tests such as urodynamic studies and a USG with a post void residue. Why? Because if by chance you might end up giving a medication for incontinence that might increase the post void residue or cause retention of urine in the patient, this can predispose the patient to urinary tract infections. Which brings us to an important point, that urinary tract infections are extremely common in patients with diabetes, especially women with diabetes. And when you see your patients for repeated follow-ups, please make sure that urine questions related to passing of urine, whether there is burning micturition, whether there is incontinence, whether there is feeling of incomplete evacuations, these have to be a part of your regular questioning. So that was about autonomic neuropathies. Of course, autonomic neuropathy presents in other ways, such as cardiac problems. So this is just a typical case. We have already discussed the treatment, but I will just go through it once more because it's so common. So you have a 55-year-old male type 2 DVN for 10 years, nocturnal burning, numbness in feet. When you check, you find absent ankle jerks, reduced vibration strengths, but motor power is normal. This is distal symmetric polyneuropathy, most common complication of diabetes. Now, this is the management, and we all know this, but what we forget is foot care education. Foot care education is extremely important. And I'm sure there are some podiatrists who will be taking lectures for you similarly like I do. They will be able to give you better information about foot care, but very basic foot care, like do not wear chappals, wear socks and shoes. Try to make sure that you check your feet every day. Don't bath with very hot water. Post bath self-examination of feet. All of this plays an important role. Of course, supplementing B12 is extremely important. And I have discussed it on this platform before that metformin, taking metformin in large doses for a long period of time can also cause interference with absorption and mechanisms of B12. And hence, patient on metformin has to compulsorily be given better B12. Just giving a B12 tablet is not important. You have to continuously check these levels and find out whether the patients are actually replenished or not. I personally use, for myself and for my patients, a lot of these subcutaneous injections of B12 that are available. They are less painful than the IM preparations, and they are better absorbed than your tablets. So if you think that they are worth your while, then maybe you can use the subcutaneous preparations too. Keep in mind that sometimes the presenting complaint is burning feet. So a patient who is not diabetic comes to you one fine day with complaint of burning feet, please get HbA1c checked. And as my revered teacher, Dr. Sarosh Katrak sir would always teach us that if a person has burning feet, then the differential diagnoses are number 1 diabetes, number 2 diabetes, number 3 diabetes, and then the rest. So even if your HbA1c is normal or borderline, and if your fasting blood sugar is also normal, in this particular patient who has burning, please get an oral glucose tolerance test done and check whether there is a possibility of diabetes, because you have to rule out diabetes. Only then will you think of other things. So this is just a diagram showing what happens, how and why does diabetes cause nerve damage by affecting the vessels. Now coming for the mononeuropathies. The mononeuropathies are either cranial or focal in the limbs. So one is the cranial nerve 3 paralysis. I think we are all aware of the cranial nerve 3 paralysis with pupillary sparing. And a lot of times we see these patients and there is a panic about a stroke. Correct panic. Please get a scan done. Very difficult to sometimes, especially in patients who have undergone cataract surgeries, to find out the pupillary actions might be a little difficult. I agree. Again, sixth nerve paralysis, there is it's a red flag if you have raised intracranial tension. So many of these patients also have hypertension, and you're always worried that maybe this is a bleed, maybe there is a raised ICT due to some other reason. So of course, in a patient with diabetes, you must get a scan done. But if your scan says that it is normal, then you're probably dealing with one of these focal neuropathies. Median ulnar nerve entrapments are very well known, CTS, that is carpal tunnel syndrome, and ulnar nerve entrapments. So this is what happens. What happens is that you have the vasa vasorum, which supplies the part of the nerve, but not the pupillary fibers, because the pupillary fibers are supplied differently. So what happens is that when you have diabetic third nerve paralysis, you have pupillary sparing, which is pathognomic. So very nice diagram here that if the posterior communicating artery is involved in the form of a PCOM aneurysm, then your pupillary fibers are compressed, which are peripherally located, and you get pupillary dilatation, which is third nerve paralysis involving the pupil. And if your vasa vasorum is the cause, which is the case with diabetes, you get third nerve paralysis with pupillary sparing. This is a diagram depicting the lumbar and the sacral plexus, and we just spoke about the lumbar and the sacral peripheral neuropathy, the plexopathies, the radiculoplexopathies. So I just want you to look at this diagram a bit. So little bit difficult to understand, but these are the two plexuses that are formed from the nerves, the nerve roots of the lumbar roots, that is the L1 to the L5, and the sacral roots. And if you see, there are quite a lot of nerves which supply the lower limb, which are present here. You might know the names of a few: the iliohypogastric, the femoral, the obturator, the sacral plexus, of course, supplying the superior and inferior gluteal, that is the back, and the sciatic nerve. So a lot of patients would be coming with these problems, and I'm sure I know what's going on in your mind. It is, how do I decide whether it is a plexopathy, whether it is just a compression due to one of the slip disc, something like that, not quite sure. So of course, it's a very common problem in everyone's minds, and the best way to diagnose this is a clinical examination. It will give you some hints, but gold standard will remain nerve conduction studies. So nerve conduction studies can help you differentiate root lesions. So when you usually have spondylosis, spondylolisthesis, spondyloarthropathies, these cause root lesions, and sometimes they cause lesions of the ventral rami that are exiting the root. And your neuropathies, plexopathies, they do not cause root lesions, they cause nerve lesions or plexus lesions. So your nerve conduction studies, your EMG, help you localize the lesion based on certain findings in the EMG or the nerve conduction, and this localization will help you, or lead you rather, to the cause. So diabetic amyotrophy is actually a radiculoplexopathy. It has very bad hip and thigh pain, and sometimes it also causes weight loss. It might be immune mediated in certain people because it's not always associated with increases in blood sugar. So your peripheral neuropathy has got a very linear relationship with increasing in blood sugar. Your amyotrophies or your cranial neuropathies often do not have a linear relationship with blood sugar. So you have patients come and tell us, मेरा sugar level तो ठीक है, तो फिर क्यों neuropathy हो रहा है? Sometimes could be immune mediated. So treatment is glycemic control, and sometimes, as I mentioned, you might need short course of corticosteroids here as well as in the mononeuropathies. So these are the autonomic complications. We have discussed them pretty much in detail. I discussed the GI very well, the genitourinary also. Another thing is we come from a very secluded social system where talking about erectile dysfunction is a taboo topic for many. But if you have a patient who is a relatively young male and he has diabetes, as the general practitioner, my suggestion is if you don't ask, who will ask? You are the person who is closest to the patient, who are the person who is most comfortable with the patient. And at the end of the day, we have to make sure that everyone's lives are enriched and everyone's lives are, you have to improve the quality of life as a doctor. So always remember this as a general practitioner, because if you don't ask, who is going to ask? And they might be more comfortable with you. So always ask about ED. Again, like I mentioned about peripheral neuropathy, that sometimes the first thing that happens is peripheral neuropathy, and then you have to tell the patient, get your sugar checked. Somewhere in a young male, erectile dysfunction, also one of the things which you should definitely get checked is blood sugar. Coming to my question, which I had asked you about orthostatic hypotension, how many people check their BP in lying down and standing position? So, as a neurologist, let me tell you, most common referrals after headache are chakkar. Headache, of course, most common, but after headache, most common referral is chakkar. And chakkar ka chakkar बहुत problematic chakkar है. So the patient comes and sometimes the patient is Marathi and the patient will say, मी उभी राहते तेव्हा मला कसं तरी वाटतं, असं गरगरतं, असं वाटतं बसून जाऊया. Or if the patient is talking in Hindi, they will be like, बस खड़े रहने को मत बोलो, बैठ जाएंगे लेट जाएंगे तो बहुत अच्छा लगता है. So if a patient is telling you this, the patient is literally pointing you towards the diagnosis. And I think the one thing which I find doing every day in my clinic is आप लेट जाओ, आपका बीपी देखते हैं, आप खड़े हो जाओ, आपका बीपी देखते हैं. And the patient more often than not tells me, मैम ये तो कभी किसी ने नहीं किया. So if you don't look for it, you'll never find it. Please make sure that BP is checked in lying down and standing positions. Orthostatic hypotension is a fall by 20 milligram, 20 mm of mercury systolic and 10 mm of mercury diastolic in standing position compared to lying down. You have to check immediately after standing and then again at 2 minutes. Make sure that the patient is not holding on or taking any support when you check the blood pressure in standing position. Now, a lot of you will tell me that, Dr. Natasha, we've listened to your earlier talks and now we check at orthostatic hypotension, but what will we do about it? Diagnose करके क्या कर लेंगे? So what are the things that you can do about it? Number one, you can check whether the patient is on anything that can exacerbate orthostatic hypotension. So your alpha blockers, again, going back to the urinary complications. So what happens? You have a patient with diabetes, the patient has some urinary complications, you've seen a urologist, and some alpha blocker has been started. And that can cause a orthostatic hypotension. So, or it can exacerbate an already pre-existing orthostatic hypotension. So you are trying to treat one complication and in the process you've caused another one. But if you learn to notice it, if you learn to look at it, and if you learn to alert the patient about it, then the other specialist can also change the medications accordingly. So especially in some person who you have recently started on an alpha blocker, be very careful. Who are the other people at risk? Somebody who sent to the cardiologist because of pedal edema. And what did the cardiologist start? Some form of diuretic. So diuretics are also known to cause postural hypotension, as are many other medications, also beta blockers. So this is something which is an often misdiagnosed, often not looked for complication of diabetes, and we should make sure that we look at this complication as well. Sorry, I think you just lost me over there for a minute. I am back now. Some network error. I apologize for that. So orthostatic hypotension has to be looked for. Orthostatic hypotension needs to be checked Moving on, what do you do? Now you know the patient has orthostatic hypotension. What do you do now? Stockings. First defense is stockings. Secondly, whatever medications that I just spoke about, if some alterations can be done, if some changes can be made, then you make those changes. Third, you can start some medications for orthostatic hypotension. So one of the medications is midodrine and another medication is fludricot. And your neurologist or your cardiologist will help you with adjusting the doses of these medications. Now coming to the central complications, of course, the number one complication is stroke. I think we have all had patients with stroke and we all know how stroke is involved, how diabetes causes stroke. Multiple times you've been speaking about this. The only preventive strategy for stroke literally that we have is screening and ensuring that you give antiplatelets on time. But also we have cognitive dysfunction, and I'm sure you have attended more than enough webinars and conferences which have told you that there is type 1 diabetes, there is type 2 diabetes, and dementia is nothing but type 3 diabetes. So be mindful of checking the mini mental status examinations of your patients with diabetes. Also, sometimes patients with diabetes have what we call micro strokes, okay, or lacunar infarcts. And a lot of these lacunar infarcts can also cause vascular dementia. So be mindful and keep checking their cognition as well. And then we have encephalopathy, which is actually not a very common problem with diabetes, pretty rare. What is more common is DKA associated hemichoria and other movement disorders. So what happens is when you have DKA or even when you have non-ketotic hyperglycemia, either of the two, a lot of these patients are in the ICU and they will call you and say कि अचानक से हाथ हिलने लगा है, डॉक्टर बोल रहे डायबिटीज की वजह से ऐसा हो सकता है क्या? तो प्लीज हाँ बोलना, because we see this quite a lot and the treatment is only correction of the blood sugars. And once the blood sugars are corrected, we initially do start the patient on some or the other medications, but they usually come around once the blood sugars are corrected. Now we have a small case study again that a patient comes with right-sided weakness, you find a lacunar infarct. Of course, you give antiplatelets, statins, glucose, secondary prevention is emphasized. Every patient with diabetes, even somebody who has not had a stroke, should be taught primary prevention of stroke. So what is primary prevention? Keep your glucose in check, blood sugar, keep your blood pressure normal, and I think we have also spoken about this multiple times on this platform. Check for sleep apnea. Your diabetic patient, there is a good chance that the patient is obese, the patient is overweight. Ask about sleep, check about sleep apnea. Correction of sleep apnea in a patient with diabetes before something else can happen acts as a very important preventive strategy for any central complication of diabetes. This includes stroke, this includes dementia. So these are your investigations and what they can be used for. As I said, nerve conduction study and EMG confirms the type of neuropathy. It helps you differentiate because, as I said, see, these patients don't come in isolation. A patient with diabetes will not have just diabetes. So nerve conduction study. Sometimes you have got quantitative sensory testing. This is for very, very early sensory neuropathy detection. You have the autonomic function tests, but the most important autonomic function test is what you do in the clinic. Orthostatic tachycardia, orthostatic hypotension, please look for that. And your MRI brain will help you with the stroke, also with dementia. Sometimes you might want to use a PET scan in patients who are showing signs of early dementia or signs of minimal cognitive impairment, in addition to a detailed neuropsychological examination. So this is what your neuron is saying, that you should never sugarcoat it. All of your neurons are saying that you should never sugarcoat it and you should always keep your glucose in check. So these are very simple steps that we all can follow. And as you can see, it's in a step ladder pattern. So number one, I think there should be a number 0 before this, which is screening. Should make sure that everyone is screened. Earlier, they used to say screen people above 40. Now I would say screen people above 30. Make sure that diabetes screening is on point, because if you catch them early, the neurons, the nerves, they all really benefit. And you remember that Fataka wala diagram which we had shown? I think the most problematic area which is burnt by that Fataka, that diabetes unfurls in the body, is the neuropathy. Because, it is non-reversible beyond a certain point. So if you catch it really early, you can prevent it from going further. But once you have got really damaged nerves, there is little that you can do. And when these patients come to us eventually with very bad distal neuropathy, there is often, we have to tell them that we can manage your pain, but that's about it. We can't help you. So make sure that there is early screening. Focus on maintaining stable blood sugars. You have to have the help of the dietitian. Medications alone do not control blood sugars. So, the three pillars, which is medication, diet, exercise. Of course, for neuropathic pain, we have gabapentin and we have other medications, pregabalin, duloxetine, all of these can be used. One more medication that we use very common is alpha lipoic acid. Alpha lipoic acid, omega 3, omega 6. These also help to get better nerve health, and you can definitely use them in your patients with diabetes, in addition to vitamin B12 and D3, which we check for all patients. Physiotherapy is important. Foot care is of extreme importance. We have to try and avoid an ulcer at all costs. And what works best is empowering with knowledge. We have so much of social media available. We have so many platforms available to teach patients. Make sure that your patients are well educated, because it's only once you know the complications that you can look out for them. So patient education, I'm sure, is something that you all do, but continue to do it in better ways. So what can we do, or what can a patient do? You have to do foot exam. Of course, foot exam by yourself, I mean the patient self daily, and foot exam by a certified doctor at least once in a year. You can test with monofilament. So that is the gold standard, that you test with monofilament, and you always look for vibration using the 128 hertz tuning fork. The 256 and the 512 work better for checking the hearing. The 128 hertz tuning fork is the one that is used to check for vibration. You get the fork to vibrate and put it at bony points, all the bony points, and check it. You can put it at the ankle. So that's how you put it at all the bony points, and that's how you check. You monitor blood pressure, you check the lipids, and you check the HbA1c and keep it under control. You have to check for autonomic dysfunction. We have already discussed about how. So basically, neurological complications in diabetes are like an iceberg. And what happens is that the patient can only see the tip of the iceberg, and the patient comes to us and says that, डॉक्टर ये तो अभी अभी हुआ है, पहले तो कुछ भी नहीं था. And then below all of that are your Pandora's box, which can open. I think the limited GP awareness part is now slowly fading, but I will still use it for the autonomic complications. So this last point is just for the autonomic complications, whether it is the diarrhea, constipation, gastric emptying time, whether it is the urinary, whether it is the orthostatic hypotension, tachycardia, and other things. I think a bit more awareness that the problems with diabetes are much beyond peripheral and central. They are also autonomic. Overlapping symptoms, we have spoken about that most of these patients also have some sort of back issues, some spondylolisthesis, spondylosis, and hence you are unsure. Whenever you are unsure, ask for a nerve conduction test or an EMG, and an EMG in certain cases. And this will help you clarify your doubts, in addition to getting an MRI of the lumbar spine done. Of course, poor glycemic control is something that all of us are collectively responsible for, including the patient. So the patient has to be educated that they need to focus on better sugar control. And I think early referrals to concerned specialists will help make the lives of diabetic patients much better. So these are the key messages. And let's take the quiz again. What is the most common neurological complication of diabetes? Can diabetes cause focal cranial neuropathies? Is diabetic neuropathy reversible? Name one non-peripheral neurological complication of diabetes. And what is the gold standard test for diagnostic diabetic neuropathy? These are the answers. Most common is, we discussed, distal symmetric peripheral neuropathy. Yes, third nerve, sixth nerve, median nerve, ulnar nerve, a lot of focal cranial neuropathies can be caused. So just remember, advanced diabetic neuropathy, advanced diabetic central nervous system complications, advanced diabetic autonomic nervous system complications are not reversible. By the time that the patient with polyneuropathy reaches a neurologist, there is already B12 has been given, gabapentin or pregabalin has been given, duloxetine has been added, and then there is very little that we can do. So when that kind of patient comes to us, we are also going to do the same things. We are going to give more B12. We are going to probably add an alpha lipoic acid or an omega-3 or an omega-6 or one of the newer nerve tonics that have come up. We will add some. Sometimes we will add L-arginine, sometimes we'll add lysine. All of these, not really sure how much that is going to work. Whereas the one thing that 100% works across multicentric data analysis and randomized control trials is early detection and tight control of diabetes. So that's important, because beyond a point, you cannot reverse diabetic neuropathy. We discussed many non-peripheral neurological complications. You must remember this thing that they keep talking about type 3 diabetes. Cognitive decline is such a reality in the lives of patients with diabetes, and having conversations early on really helps set the tone. And gold standard is nerve conduction studies. So what are your take-home messages? Many neurological issues. Prevention is the best therapy. And yes, absolutely. If you are detecting early, treating early, referring early, it can dramatically reduce disability. So that's it. I think the floor is open so I'm going to stop sharing my slides now. And we might just see if we have any question answers or anything in the chat box.
Thank you very much, madam. There are some questions, madam.
Yeah, so you should give statin. You should give statin to all. One second. You should give statin to all strokes, whether they are because of diabetes or not. I'll just go through it again. Vibration, sensation in toes, that is basically paresthesia. So any form of paresthesia needs to be treated with the same medications that you would use for basically painful neuropathy. Pentoxifylline, that is not very clear. What I recommend for the use of pentoxifylline is that you can get a lower limb arterial Doppler done. And then should you find any arterial insufficiency, then maybe you can go ahead with pentoxifylline. Treatment of axonopathy, steroids. Okay, I guess that's it. Anything else? Let me know.
Dr. Archana Satara has asked, please repeat medicine names for orthostatic hypotension.
So one is midodrine, midodrine, which is available by the brand name Gutron. One of the brand names, but the name of the medications is midodrine, midodrine. We start with a 2.5 milligram dose. Good medication, usually works well, but I would always try stockings first, because most of the diabetic patients are also, in one way or the other, they have some cardiology issues. And if you want to give any of these medications, you have to consult your cardiologist, because Fluoricort increases the fluid volume in the body. So the nephrologist and the cardiologist will have to be asked about it if you're giving Fluoricort. It is fludrocortisone. And midodrine, again, have a word with your cardiologist. Make sure that the cardiologist is happy on board and only then start. Something that you can universally start without any stress is stockings. And ask the patient to exercise their legs enough. So you activate the leg pump, which is our second heart of the body, and that makes it easier for the blood pressure to be controlled better.
Yeah, there's one more question, madam. Does CP key rise in proximal plexopathies?
If there is an amyotrophy, which means if there is wasting of the muscle, then yes. Otherwise, no.
Okay. Dr. Meena has asked, madam, how long can a patient take fluidicot?
As long as the cardiologist and the nephrologist don't have a problem with it.
Okay. Dr. Amar has asked, is there a role of benfomamide in diabetes neuropathy?
Yeah, so benfomate is basically a combination of multiple B12, B6, multiple B vitamins, and the other compounds which I mentioned, the L-arginine, the lysine. You can give it. Most important point is to make sure that your B12 levels are corrected and your sugar is okay. This helps. It does help. There is no doubt that it helps, but it helps in minor ways. So 60-70% of your job is just done with supplementing B12 and making sure that the sugar is under control.
Okay.
This will be the rest of your 20-30%.
Right. Dr. Prajakta has asked, could you please explain again the CNS involvement slide?
Yeah, so basically, I mean, the slide didn't contain anything great. CNS involvement is the first thing is stroke. So a patient comes to you with diabetes, you have to be on the lookout for stroke and vice versa. Someone who's come with the first time with a stroke could have diabetes. So central complication. So diabetes always causes your microvascular and macrovascular complications, right? So for your central nervous system, the macrovascular complication is stroke and the microvascular complications are lacunar stroke, and the second being your type 3 diabetes, which is your dementia. And quite a lot of people actually come with dementia once they have 15-20 years of diabetes in them. So sugar control is extremely important in these patients. Also important to sensitize them about dementia, because as such, honestly, the treatment options for dementia are limited. But you might want to start them on a donepezil or a rivastigmine if they are diagnosed early. Again, dementia standard protocol holds true for diabetic patients also. Okay, so you have to think about checking the thyroid levels. You have to think about B12. Every patient with diabetes, B12 and diabetes treatment go hand in hand. And I mentioned about metformin, that has to be kept in mind. Homocysteine, somebody has asked, yes, it does cause stroke because it interferes with B12 metabolism. And that is how it causes stroke.
Dr. Amit.
Hypercoagulability, basically. Homocysteine causes hypercoagulability.
Dr. Amit Thakkar has asked when to use PG and when duloxetine.
They are actually both very useful medications. Duloxetine has more of effect on patients who also have some element of stress or anxiety or related. Yeah.
There's one more question. Any good ointment for burning feet? Also a good nerve tonic or something?
A lot of preparations are available which contain pregabalin and gabapentin in addition to your usual things which we have to use, which is the capsaicin. So any combination of a pregabalin and a capsaicin or a gabapentin and a capsaicin is a good ointment to use. And nerve tonics, pretty much, as I think I've already answered, they contain the same things. So you can use whichever your patients prefer. Also, D3 correction helps. So if your nerve tonic also has D3. But for D3, again, we've discussed it on this platform. Keep a tab on D3 because I see a lot of elderly patients with D3 levels of 90 almost every day. So ask the patient to keep a tab on how much D3 they are taking, how they are taking, and make sure that, that's taken care of.
Okay, ma'am. Dr. Prajakta has tuning fork test 128. Can you please explain more?
So there is a tuning. You want me to show the tuning fork? I actually have it in my bag. Just give me a minute. I'll show it. No problem. I have it in my bag. Just a minute. This is a tuning fork. This is
Yes,
what a
ma'am.
tuning fork looks like. So what you do is you do this. Now it is vibrating. And then you place this on the bony prominence like this. And you ask the patient to tell you, first of all, you do this. You ask the patient to say whether it is vibrating or they can feel the vibration. Now, the good thing about mobile phones is thanks to mobile phone, everyone understands what vibration means. So you don't have to explain
Yes,
it to
ma'am.
anyone anymore. Then you do this and you put it on the bony prominence. You can do this on the lateral malleolus in
Okay,
the
ma'am.
feet. And then you just hold and you ask the patient to tell you when the vibration stops. Usually you can also feel the vibration because you're holding the fork. Okay. So ideally the patient should tell you only when the vibration has stopped. And the most ideal way to do it is the patient, then you put it on yourself and assume that your vibration sense is normal. And if you can still feel it. There are certain quantitative tuning forks also available, but usually this works. This works very well for checking vibration sensations.
Yes, Dr. Leena Bhagat has asked brand name for subcutaneous
Um,
B12.
I'm not sure this is a platform where we should be taking brand
Okay.
names. You can contact your medical practitioners for the same and they will let you know. Almost all of the major, let's just put it this way, almost every single major pharmaceutical company that that has a B12 preparation which can be taken orally has come up with a subcute. So you
Okay,
contact
ma'am.
whichever pharmaceutical, the ones oral that you prescribe to patients, they have subcute.
Okay,
Everyone,
ma'am.
the every single pharmaceutical company has a subcute now. Gabapentin usually does not cause dementia in small
Okay.
doses. The thing is that in your brain there is a GABA system which quietens your brain. And there is a glutamate system which excites your brain. Now your if your GABA system is overactive, it can cause some slowing, which does not mean dementia. It just means that you're a bit sleepy. So if you're giving a lot of gabapentin, it has the same effect as an anti-seizure medication. And I'm sure a lot of you will remember that gabapentin initially came in as an anti-seizure medication, and
Right.
then it was diverted to peripheral neuropathy. But it does not cause dementia. No.
Okay, ma'am. There's one more question. Last, Dr. Amit Thakkar has asked B12 subcutaneous or IM?
Subcute works as well as IM. So if you're really
Okay.
comfortable with IM and your patient also wants an IM, go ahead. But subcute works as well as IM.
Okay. There is Dr. Meena has asked, are B12 stripes effective?
Strips, yes, they are
Yeah.
very effective. They are used for sublingual absorption. They are very
Okay.
effective, but I would still feel that if the B12 is really low, you might want to go with at least a subcute injection.
Okay, ma'am.
Okay, and
Yes,
one
that's
more
all.
thing.
Yeah.
For neurology, the normal B12 level is upwards of 300, and for a patient with diabetes, it is upwards of 400 in most of the labs. So if your lab has a normal B12 range is 180 and above, which is majority of the labs. Remember that for your neurology patients, 130 and above, and diabetic patients, 140 and above. So even if it is 120, please give the patient one shot or give some medicines to take. More than 200 would be fantastic. If it is more than 200, if you can maintain it more than 200, it would be fantastic.
Even this nasal spray in B12 is effective?
Yes, yes, sir. So intranasal, sublingual, and subcutaneous are more effective than oral absorption.
Dr. Dipali Kini says, how long can we continue with gabapentin?
There are three problems here. Number one is the somnolence. Number two is the tolerance, because so sort of, the patient needs more and more and more and more and more. And number one is the somnolence. The patient feels sleepy. And number three is that often the patient themselves will come and tell you कि अभी कुछ और medicine try करके देखते हैं. So we have given gabapentin for many years to patients altogether, 2 years, 3 years. But you might want to switch in between if the patient feels that they are not responding to the medication.
So one more question, Dr. Meena, is how long B12 injection should be given?
You have to check B12 levels.
Okay.
That's the only way to. And please check B12 levels fasting. And if you're giving a B12 injection, check it a week after taking the injection. Otherwise, you will get ridiculous levels like greater than 2000, which just means that something
Correct.
has been recently given.
Yes, ma'am. That's all, I think.
All
Thank
right,
you
sir.
very
Thank you
much.
so much. Thank
Yeah.
you very much for chairing the
Yes.
session and asking the
Yeah.
questions in a rapid fire way.
Yes.
Yes,
On
thanks.
behalf of General Practitioners Association and collaboration with Jaslok Hospital Research Center, I sincerely thank our speaker, Dr. Natasha Tipnis, for a wonderful and enlightening session. I also like to thank all our participants for joining us online and making this webinar 297 a success through your presence and interaction. And a big thank to our technical team and the organizer, Dr. B.K. Dolokia, Dr. Bharat Bhatt, Ms. Ajita Bosle, and our organizer, this thing, the Avinash and Pranav. And thank you once again. We hope we meet you all the next webinar. Thank you.
Thank you so much,
Yes,
sir.
ma'am.
And thank you once again to the GP Association for giving me this opportunity to speak. As I always say, and today more than ever, that somebody who has a very caring and a very vigilant GP should not develop any of the neurological complications.
Correct,
So
ma'am.
here's wishing that none of your patients develop neurological complications of diabetes. And wish you all a very happy rest of the day. Happy evening to all of you.
Thank you. Thank you,
Goodbye.
ma'am. Thank you. Sir, you're going to announce the next.
Yeah, we are meeting next week to listen to Dr. Kunali Musala, neurocognitive disorders. Neurocognitive disorders, Dr. Kunali Masala.
Okay, sir. Thank you, sir.
28th November, 2:30 sharp.
Thank you, sir.
Thank you.